Welcome to the deep dive. We take your notes, your articles, all that research.
A big stack of stuff.
Exactly. And we dive in, pull out those crucial insights, the things you really need to know, and give you that high-yield understanding. Fast. Today, we're zeroing in on one specific topic, cutaneous larva migrans. We've got some pretty comprehensive revision lists here.
Yep.
And our mission, to basically turn these notes into something clear, memorable, perfect for revision without you having to wade through pages and pages.
And it's actually quite a fascinating condition. The notes mention this creeping eruption idea.
Creeping eruption.
And it's very relevant, especially, with more people traveling, sort of highlights how these things spread.
Okay, let's get right into it then. Unpack this. What is cutaneous larva migrans, fundamentally?
Right. So at its core, it's a skin infection. But the key thing is, it's caused by larvae, specifically the larvae of animal hookworms.
Animal hookworms.
Yeah. And it happens when these tiny larvae, they get into your skin directly, usually from soil or sand that's contaminated with animal feces containing the eggs.
So a parasite from an animal gets into a person.
Exactly. But here's the twist: it gets stuck. It tries to complete its life cycle like it would in a dog or cat, but it can't in humans, so it just stays there in the skin.
Okay, stuck in the skin. So where do these particular larvae come from? The notes mention specific types. What's the etiology here?
Yeah, the source material is quite specific. It names the main culprits. Number one is usually Ancylostoma braziliense.
Braziliense?
Yeah, that's often linked to dogs and cats, especially in, tropical regions. Then there's Ancylostoma caninum.
Caninum, okay.
Primarily dogs for that one, and the notes actually mention it specifically in relation to Australia, for instance. There are other rarer ones, but those two are the ones you'll likely encounter most. And this brings up a really important point, something the notes differentiate clearly. These are not the same hookworms that typically infect humans internally.
Ah, right, like the ones causing gut problems.
Exactly. Things like Necator americanus or Ancylostoma duodenale.
Ah.
Those can live and reproduce inside us, causing diarrhea, malabsorption, that kind of thing. But the ones causing CLM, they're usually animal parasites taking a wrong turn, basically.
Okay, that distinction's key. So they take a wrong turn into us.
Yeah.
Why do they just cause this skin thing? What's different about their life cycle in a human?
Right. So think about the normal cycle in an animal. Eggs are passed in feces, hatch in warm, moist soil, larvae develop. These larvae then penetrate the animal's skin or get ingested.
Okay.
Then they travel through the body, maybe lungs, get coughed up, swallowed, end up in the gut, mature, lay eggs, cycle complete.
Right.
But in humans, we're sort of an accidental or dead-end host. The larvae penetrate our skin, sure, but then they get stuck. They don't have the right biological cues or enzymes to migrate deeper or mature properly in us.
So they just wander around under the skin.
Pretty much. They migrate horizontally within the upper layers of the skin, the epidermis, and maybe the top of the dermis. They can't complete the journey, and that is why you get the skin lesions, the tracks, instead of an internal infection.
That makes perfect sense. A dead end for them, but a very annoying one for us, I imagine.
Extremely itchy, yeah.
So who's most likely to run into this? What are the risk factors you should be aware of?
Well, based on how it happens, the risks are fairly logical. The biggest one, walking barefoot, especially on soil or sand that could be contaminated.
Beaches, playgrounds, that sort of thing.
Exactly. Also, frequent contact with pets, especially stray animals in areas where it's common, increases risk. And a big one for many listeners perhaps is travel, living in or visiting tropical and subtropical regions. That's where these hookworms thrive.
So definitely something for travelers to keep in mind.
Absolutely. It's often considered a travel-related infection in places like the UK.
Okay, now, pathophysiology. This sounds like where we get the creeping eruption explanation. How does that larva, stuck and migrating sideways, cause the actual symptoms?
Precisely. So after it penetrates, it starts moving, but only horizontally through the upper skin layers. As it tunnels along, it leaves behind that characteristic track.
The track.
Yeah, the notes describe it as serpiginous,
Which means?
wavy, snake-like.
Mm-hmm.
It's also erythematous, meaning red, and intensely pruritic, which is the medical term for incredibly itchy.
Okay, red, wavy, itchy tunnels. Got it.
Right. And because the larva is constantly moving but can't go deeper, it just keeps extending this tunnel sideways. That continuous shallow migration is the creeping eruption. It's literally creeping along under your skin.
Wow.
And this movement, this foreign body reaction, it triggers inflammation and that really intense itch. What's also interesting, and kind of reassuring, is that the larvae can't survive indefinitely in us. They eventually die off, usually within weeks to maybe a couple of months.
So it goes away on its own.
It is typically self-limiting, yes. But the symptoms can be so severe, treatment is usually wanted to speed things up dramatically. Waiting it out isn't fun.
Okay, self-limiting but intensely itchy tracks. Understood. Let's talk epidemiology. Where does this actually happen? Who gets it?
Geographically, think warm, moist climates. Tropical and subtropical regions are the hot spots. The Caribbean, Central and South America, Africa, Southeast Asia. A lot of popular holiday destinations, actually.
Right.
So for listeners in, say, the UK or cooler parts of North America, most cases you'd see are imported, some of them traveling.
Makes sense.
In endemic areas, it's pretty common, especially in children who might be playing in contaminated soil more often. But globally, considering travelers, it really affects all ages.
All right, let's get to the clinical features. What would you actually see and feel? Describe that rash again.
The absolute classic sign, the thing to really look for, is that track. Erythematous red, pruritic, intensely itchy, and serpiginous winding or snake-like.
And where does it usually show up?
Most commonly on the feet because of walking barefoot, but also hands, buttocks, basically any area of skin that came into contact with the contaminated ground. The notes also mention abdomen, anogenital region, anywhere exposed, really.
And the feeling, just itching.
Intense itching is definitely the main complaint, often described as unbearable. Some people might feel mild pain or a burning sensation along the track too. And often there's an initial tingling or prickling feeling right where the larva entered, maybe a few hours or days before the track appears.
Okay. And you mentioned something about it moving.
Yes. This is a key diagnostic clue, a great memory aid from the notes. The track advances, it creeps forward. The rate mentioned is typically between 2 millimeters and maybe 2 centimeters per day.
Per day. Wow, you could almost watch it move.
You really could, over a few days. That movement is highly characteristic of CLM.
That movement seems like a huge giveaway. But still, any itchy rash needs. You know, thinking about other possibilities. What else is on the differential diagnosis list?
Absolutely. You always consider other causes of itch and rash. But, as the notes stress, that specific linear, winding, migrating track is usually quite distinct for CLM.
So what else might look a bit like it?
Well, things like scabies that causes burrows and intense itch. But the burrows don't typically migrate in that linear advancing way day by day.
Yeah.
Allergic reactions, contact dermatitis, they cause rashes, sure, but not usually these defined moving lines.
Okay.
Other possibilities listed include other parasitic infections, maybe some fungal infections like dermatophytoses, or even erythema chronica migrans from Lyme disease.
Lyme disease, right?
Yeah, that can be a migrating rash, but it usually looks different, more like an expanding ring, not a thin, winding line.
Yeah.
Photoallergic dermatitis is another one mentioned, but really that advancing track is the big differentiator.
So if the track is so characteristic, how do doctors actually confirm it? Are tests needed?
This is a really important high-yield point for anyone revising this. The diagnosis is almost always clinical.
Clinical, meaning?
Meaning it's based on seeing that typical migrating eruption and getting the right history. History of exposure, like recent travel to an endemic area, walking barefoot on a beach, guarding without gloves, that sort of thing.
So usually no blood tests or biopsies.
Exactly. The notes are clear.
Yep.
Lab tests are generally unnecessary. That's key. Don't jump to investigations for a classic presentation. Now, if the picture is really unclear for some reason, the notes have mentioned some possibilities. Skin scrapings or a biopsy might show the larva microscopically, but finding it can be difficult, and it's not standard practice.
Okay.
There's also mention of optical coherence tomography, OCT. It's like an optical ultrasound for the skin. It can actually visualize the larva non-invasively in the epidermis.
Wow, really?
Yeah, pretty neat. The notes even suggest it could potentially help guide removal, but its main role would be diagnosis in very atypical or confusing cases. But again, for most people, visual diagnosis and history are enough.
Okay, clinical diagnosis is key. Got it. So once you've diagnosed it, how do you manage it? What's the treatment?
The main goals are simple. Relieve that awful itching and kill the larva faster than it would die naturally. So the mainstay of treatment is antiparasitic medication.
Specific drugs.
Yes, the notes name the common ones. Topical treatments can be used, but often oral medication is preferred for convenience and maybe effectiveness. The main drugs mentioned are albendazole or ivermectin, usually just a short course.
Albendazole or ivermectin.
These work really well to kill the larva.
What about antibiotics?
Good question. Antibiotics might be needed, but only if the skin gets a secondary bacterial infection. From all the scratching breaking the skin. They don't treat the larva itself.
Right, just for infection from scratching.
Exactly. And, of course, part of management is reinforcing that prevention advice we talked about to stop it happening again.
And how do people generally do? What's the prognosis? Any nasty complications to worry about?
The prognosis is generally excellent. That's important to remember. And, as we said, it's typically self-limiting.
Right, the larva dies on its own eventually.
Exactly. But treatment makes a huge difference to how quickly the symptoms resolve. With treatment like albendazole or ivermectin, the itching usually improves dramatically within a day or two, and the tracks fade over, say, a week or two, much faster than letting it run its course. As for complications, thankfully they're not common. The main one, as mentioned, is secondary bacterial infection of the skin from scratching, impetigo, cellulitis, that sort of thing.
Okay.
The notes also mention the rare possibility of ectopic migrations, meaning the larva somehow moving outside the skin. But this is considered very unusual. Mostly it's a skin-limited issue that gets better.
Okay, excellent prognosis. Usually self-limiting, but treatment helps a lot. Let's just circle back and really nail down prevention. What are the absolute key takeaways from the notes?
It really boils down to avoiding skin contact with potentially contaminated soil or sand.
So number 1, wear shoes.
Wear shoes.
Okay.
Especially on beaches, trails, or any potentially contaminated ground in those endemic areas. Use towels or mats to sit on rather than directly on sand.
Makes sense. What about pets?
Yeah, for pet owners, especially dog and cat owners, regular deworming is important. And try to prevent pets from defecating in areas where people might walk or sit barefoot, like public beaches or children's sandpits. The notes also suggest covering sandpits when they're not in use.
Simple measures, but effective.
Definitely. Good hygiene practices generally help too.
All right. So let's try and pull this all together. We've taken these detailed revision notes and hopefully giving you a clear, high-yield map of cutaneous larva migrans. From understanding, it's caused by animal hookworm larvae getting stuck.
To recognizing that classic, itchy, moving, serpiginous track.
Knowing diagnosis is usually clinical, treatment involves drugs like albendazole or ivermectin, and the prognosis is excellent, even though it's self-limiting, and importantly, how to prevent it.
Exactly. And it really highlights how understanding that basic life cycle difference, why it gets stuck in us, explains pretty much everything you see clinically and why the treatment works. That animal versus human hookworm distinction is fundamental.
So here's a final thought for you to consider, spinning out from this deep dive. We talked about how cases in non-endemic regions are often imported by travelers. With global travel becoming so much more common, how does that change the game for diagnosing conditions like this? Does it mean doctors everywhere need to be more aware of these tropical diseases, even if they're practicing in, say, London or Chicago? What does that imply about the importance of taking a really good travel history?
That's a really interesting point. Definitely food for thought.
If you found this deep dive useful for your revision and you're after more comprehensive resources, definitely check out passthemsr.com.
They've got a lot of great material there.
And you can also find a load more free resources over at freemsri.com. Until the next deep dive.